Welcome to Hot Topics in the Anterior segment. My name is Walt Whitley, and today we're going to talk to Dr. Eric Schmidt out of Omni Eye Specialist in Wilmington, North Carolina. Dr. Schmidt, we want to talk about glaucoma. Tell us what's hot, such as, first, where are the glaucoma patients?
The glaucoma patients should be in your office, Walt. They should be in all of our offices. The demographics are rising. It's estimated the incidence for glaucoma patients is going to be about 10% by the year 2050, and those patients are right in the optometrist's office. If we look and ask the right questions, we should certainly be able to find them.
Mm-hmm. There's been several new medications on the market and different devices as well for surgery. Any comments on that?
Well, the new drugs that have come out, there's two new drugs that I think are going to have impact on the anterior surface. One is Zioptan, which is a preservative-free prostaglandin. It's unit dose vials, use it QHS just like you do with the other prostaglandins. Our experience in the clinic is it is about as good as the other ones we have on the market. Sometimes you get a real home run with these, sometimes you get an inadequate pressure drop, but I think our experience with the pressure drop on the Zioptan has been as we expect it to be, just what a prostaglandin should be. The great thing, the cool thing about the Zioptan is that the hyperemia incidence is about 3%. The SPK issues that we've been seeing because of the BAK and the SOFZIA are minimized because it's unit dose unpreserved drop, which has I think really nice impact on the surface of the eye.
Mm-hmm. So we have the medications, but we also know that patients can have comorbid conditions. Other things that, what about more aggressive treatment on dry eye before even thinking about the medications?
Well, I think obviously anytime you're going to add a chronic medication, you've got to look at the whole surface of the eye, and so concomitant therapy, even with artificial tears or taking care of the lid margin, if there's glandular dysfunction, I think that's imperative that you look at that too. You can't look at the glaucoma treatment in a vacuum. Remember, we're using this drop on an eye for the rest of this person's life.
Mm-hmm. Well, one of the hottest things we're hearing or debates is the brand versus generic. What are your thoughts?
Well, I mean, that's a great question. We've had, clinically, we felt that the branded drops seem to perform consistently better over the course of the patient's life, but we didn't have any real solid data. There's a new study that came out, it's called the DROP study, which showed that patients who were on generic letanoprost, that had been treated with generic letanoprost, then were switched to Lumigan 0.01, showed a 4 millimeter drop in pressure across, for a 12-week period across the 12-hour time period. And that's rather robust data, and it kind of lends credence to what we felt clinically was happening in our patients.
Well, Dr. Schmidt, what about Rescula? This is a prostaglandin that's been out actually it came out several years ago, and then we didn't hear about it, but now there's a resurgence.
Well, yeah, it's really not a prostaglandin. It's identified as a docosanoid, which is a different molecule. Its mechanism of action is different than prostaglandins, and so initially when it came out, it was kind of pigeonholed as a prostaglandin. It's technically not. The mechanism of action is different. It works on some different channels that help with outflow, it's new to the market. We don't have a lot of experience with it, but I will tell you this. The data shows we can expect about a 3 to 4 millimeter drop, additional drop in IOP. It's approved for adjunct therapy as well as standalone therapy. And the side effect profile on this drop is really nice. The patients seem to like it. It's very tolerant. The side effect profile on ocular is similar to what we see with timolol, which timolol has been a very well tolerated drug for years and years and years. And so not only its side effect profile is like that, but also the IOP expectations are about what timolol will give you.
And then there's another medication on the market that we're hearing about, Simbrinza. Any experience with that?
Well, we've been out for 2 whole months now, or a month. I can tell you it's approved for 3 times a day. It's a combination drop with a carbonic anhydrase inhibitor and old alpha-gain brimonidine 0.2%. The data shows a real robust IOP drop with this. Anywhere between up to 8 millimeters of mercury lowering. So it's an interesting drug. It's the first combination we have without a beta blocker, which makes it interesting. It'll be probably additive to a prostaglandin quite nicely. And with the carbonic anhydrase inhibitor it has in it, I would expect it has real good 24-hour IOP control. Quite frankly, our clinical experience is about 4 patients on this, and so I can't tell you what we see, but the data seems really interesting on this. And again, it's a beta blocker free drop, which is I think a step forward.
All right. I have one last question for you. Unfortunately, you're diagnosed with glaucoma. You had a choice between a drop versus a laser procedure. What would you do?
I would choose a drop at night.
Would you? And do you have a go-to drop?
No, I would choose. I would start with whatever my drug plan covers and go from there. Yeah. Okay. I find all the prostaglandins to be about equal clinically.
Okay. Perfect. So, do you think glaucoma's hot?
I think glaucoma is very hot. Glaucoma is on the rise. It's fun to treat. It's a practice builder, and your patients really appreciate you if you keep them seeing.
Awesome. Hey, well, thank you, Dr. Schmidt, and thank you all for watching Hot Topics in the anterior segment.